Welcome. My name is Adelina Comas Herrera, and I'm really delighted to welcome you to this webinar today. I'm going to very briefly introduce the Global Observatory of Long-Term Care. And Nabel, if you could help me with the slides, that would be great. So the Global Observatory of Long-Term Care is a platform for knowledge exchange. Our aim is to support people who are working in areas related to long-term care, and by that we do include mental health, to share their knowledge, showcase how they're addressing different challenges, and above all, supporting learning from each other, and it's open to everyone.
Hi everyone, so I'm Annabelle. I support communications for the Global Observatory of Long-Term Care. And as Adelina was saying, there's a series of publications, so that includes country guides. There's also different interest groups. Obviously, this one is the Global Perinatal Mental Health Interest Group, but we have a whole lot of other ones on different topics. You can explore those on our website, and also have an extensive list of different experts from around the world who are connecting about long-term care. We also have a repository of all of the videos of webinars like this on different topics as well.
Thank you so much, Annabelle. I just got back in, and you're doing a great job. So
Great.
just before my connection drops again, I'm just really delighted to welcome you today to this webinar of the Global Perinatal Mental Health Interest Group. And we're delighted to hear first from Annette and then from Lauren Stewart on this community health intervention through music engagement. All yours, Annette. Thank you.
Thanks so much. Yeah, I'm also trying to be quick. I have a few slides that I'm going to share. Yeah, so we created this kind of like global perinatal mental health interest group as part of this kind of like what I would call like a really great resource that is available to us. And I'm going to explain a bit more about perinatal mental health in case, I mean, most of you will know a lot about it, but just for those who don't, and why we created this group, and then kind of like say a bit about who's part of it and what we're trying to do with that. So the vision of the group, and that was decided with kind of like several people who I'm going to show you in a moment, is to kind of like bridge the data to delivery gap in perinatal mental health. So knowing that we have all this amazing information and evidence available, like, you know, we want to kind of like talk about that evidence, but then we also kind of like want to talk about how that relates to actually then kind of like using it in the real world, and ideally to kind of like sustain and scale intervention and kind of like make a difference in the field. So perinatal mental health, and again, like I'm really sorry because most of you will know that, but it's just such an important issue. So worldwide, 140 million babies are born every year. And globally, we know that up to 1 in 3 women develop some form of mental health problems during pregnancy and following childbirth. And it therefore contributes very substantially to the global burden of disease. It's increasingly recognized or widely recognized now among policymakers, national and international policymakers, and organizations like the WHO and World Bank. So we estimated the human economic cost of untreated and perinatal mental illness, and they range from 3 to 17 billion, depending on the country, per birth cohort. And so that's the kind of like lifetime cost we estimated for several low and middle income countries, as well as kind of like high income countries. And maternal depression is responsible, and that's quite powerful, I think, as a just overarching kind of like figure, 3.2 million cases of child stunting. And shockingly, also suicide is the leading cause of maternal mortality in many countries. Although obviously it's not very well established, the data are not good, but in those countries where there's data available, it shows that, like, for example, in the UK, that it's explaining up to 40% of deaths. And we have the positive thing is there is actually evidence-informed guides available on what women should receive. So there is this important guide informed by colleagues who are like Simon Honigman and others attending the meeting right now, Vivek Glover, to kind of like provide a guide for how to integrate perinatal mental health, even in kind of like resource poor setting in maternal and child health services. So why this group? So there's obviously a big evidence to treatment gap. So we know that 90% of women or more in some countries are not identified currently and are obviously not getting the treatment that they need. And so there are lots of kind of like learning opportunities and, you know, like especially kind of like research sustainability. So that's where they think this group can be strong. because there will be teams like, for example, today Lauren is presenting on it. There will be teams who are actually increasingly having a lot of knowledge about how to build kind of like capacity for change and sustain some of the interventions and scale them. And I think that's where the group can be really interesting to kind of like have those discussions and almost like utilize also hopefully in the future more of the kind of like GOLTS infrastructure, which actually provides kind of like similar topics, even though it's a kind of like long-term care sounds like a little bit of a different topic, but they're actually like very similar issues that are being discussed around integration, digital technologies, task shifting, community capacity building, and so on and so forth. And I think it's really exciting, actually. We haven't really thought in perinatal mental health, I don't think so much about the interface with long-term care systems. But in long-term care systems, organizations like the WHO are increasingly thinking about that actually long-term care systems are no longer affordable if we are focusing only at what happens during the kind of like later period of life. So they are now taking a much more kind of like life course perspective in their approach and policies. So there is an exciting opportunity, I think, to really think about how perinatal mental health fits into that. So who's leading the group? So it's quite a large group, and you can be part of it. So we are still open. It's quite a flexible group, and we haven't done a lot of intensive stuff other than the seminars. But they're really like core members who have started us off, and I'm really glad that Yafet is attending today. But there's obviously also Janet Milgram, who presented at the last meeting from Melbourne, Australia, who has done this fantastic e-treatment intervention that they have actually scaled in Australia, which is amazing, the Mahmoud booster. And then we have this amazing steering group with many of you hopefully attending today. We have seen Vivette and Simon. And so we're hoping that over time this group becomes more and more active as we're clear about what we're trying to achieve as well. So watch this space. And so this is a bit more about what we can do. So we can look at topics like digital technologies, as I said, task shifting, cultural adaptation. So that's what Lauren is presenting on, community-driven solutions, system strengthening approaches. And obviously that's, you know, where I'm obviously keen on talking about is the role of economic evidence in supporting some of it. And they're kind of like different activities for which we can become active. And Adelina and the team behind GOLTS can kind of like support us, which includes the webinars which we have right now, but there are other opportunities, including case study summaries, training or development resources, social media content, practical tools, blogs, website materials, and videos, for example. And anyone can join. I think Adelina made that already quite clear. And we are particularly keen to kind of like support early career researchers. And in the future, we had this idea that maybe it would be very nice if we had kind of like more senior people presenting with early career researchers together to almost like support and invite that group as well. And so the seminars we had is the one from Janet Milgram on scaling and treatment that took place earlier this year. Today is obviously Lauren Stewart, which is really exciting and yeah, very keen to kind of just pass on in a minute to talk about universal culturally embedded interventions in Africa. And then hopefully at the next meeting, we have Rob Stewart presenting together with Genesis Corve, and then Linus Move and Vivette Glover at the meeting after. And those meetings, they take, just because of capacity issues, it always takes about like, in the time in between kind of like webinars is always around 2 or 3 months. So it's quite a long time, but we can try and have additional webinars if we wanted to. And that's me finishing for now and handing over to Lauren. We are really excited to have you, Lauren. And yeah, I'm sure you will introduce yourself, but yeah, just, yeah, over to you.
Well, thanks ever so much, Annette, and thanks to everybody for being here this morning. Yeah, I'm very delighted to present on some of the work that I have been doing with a huge interdisciplinary team across many different continents and disciplines. Actually, since about 2017, there's 2 phases that I'm going to talk about today. And quite excitingly, we're just beginning a phase that will last for 4 years, funded by National Institute of Health Research, with Annette and Simon and Vivette on the advisory group, and a number of other colleagues. Sarah Skeen is the co-lead at Stellenbosch University. but a lot of the work that I'm going to talk about today is around a phase one of underpinning research that really led us to where we are today. So the CHIME project stands for Community Health Intervention Through Music Engagement. We're really looking at how participatory musical practices, however contextualized, can be used to support maternal mental health. Lots of the work that we've done the project started off in the Gambia in West Africa, and that's mostly what I'll be talking about today. But in the NIHR grant that we've just kicked off, we are starting to do some work in South Africa and in Lesotho with our colleagues there. Yes, so let's take it away. So I'm going to give you a rationale for why we're focusing on maternal mental health. Annette's obviously given a bit of a preview. Then the rationale for why participatory music can be useful. I feel like it's a fairly novel approach with a lot to offer. I'll talk about the road that led us to where we are now and what we're going to do over the next 4 years. So it's not new to any of you, but I always do have to point this out. Mental health exists on a continuum, not a binary state defined by the presence or absence of a condition. And that's not very well understood in some contexts, even probably in the UK as well. But it's really important to the approach that we have been taking to think about this spectrum-based model, where if you intervene to support maternal mental health, you can actually have a very wide reach. You have the potential to reduce symptoms for people who are really in experiencing distress. You have also the potential to help people exist or maintain a relatively good state of mental health as well for people who are not in that state of distress. So thinking about this as a spectrum-based model is useful, and it also in many contexts reduces the stigma associated with just selecting out people who have the highest levels of distress or a formal diagnosis, because in many contexts mental health is highly stigmatized, and that is not useful when you are trying to actually deliver an intervention. So that's how we are thinking about things. Sorry. Okay, so as you can see that we can think about the sort of different severity levels, and this is from the WHO guide. And what we can see here is that for the WHO recommends this stepped care model, where for people at many levels across the spectrum can be supported through psychosocial interventions to reduce symptoms, as well as to promote good mental health. And that's very much how we've been thinking about things. So another reason why perinatal mental health is really important, apart from thinking about the woman's own mental health and well-being, is because of the association between maternal and child outcomes. And we know that poor perinatal mental health is associated with several negative outcomes for mothers and children, some of them persisting beyond that initial postpartum period. And this schematic sort of illustrates just a few of those. So we know that there can be difficulties in terms of birth outcomes at delivery, and then in infancy, and then in younger children, and in adolescence. And some of the work here was really pioneered by Professor Vivek Glover, who many of you will know, and we've been lucky enough to be working with on this project. So as you also know, Annette's done this very important work about the economic cost of untreated perinatal mental health. So it really, if we intervene during pregnancy, that gives us the best possible chance to sort of mitigate this cycle of intergenerational adversity, rather than waiting till the postnatal stage, which of course is useful to provide support as well. But I think a lot of the evidence is really pointing for this begin before birth approach. Okay, So we know that in a low and middle income context, there's huge data and research gaps, but the particular gap that we are seeking to address here is around interventions to promote better mental health outcomes during the perinatal period. So where does music fit in? So music has been termed one of the most underutilized health assets on the planet. I have to be careful here to clarify that I don't mean that it's underutilized in communities, because in many parts of the world, it's used prolifically in informal ways and by communities. And in fact, that really underpins why we started to do this work, which is to recognize the sort of the cultural richness of community music or practices in many parts of the world. But in terms of formal healthcare utilization, it's true to say that music hasn't been really utilized in the ways that it can be. And yet it's low cost, readily available, it's widespread. And increasingly, the literature shows that it's an effective and also versatile resource for health, including mental health and well-being. If we think about group singing, we know that engagement in group singing is linked to lots of positive effects, increased joy, self-confidence, and social connection. But there hasn't been very much research or rigorous research on the potential of music-based interventions to improve mental health, particularly in low or middle income contexts. And so with this in mind, we developed a community partnership in the Gambia to develop CHIME. It's a very long story as to how I started doing this work. My own background is in the cognitive neuroscience of music, so that's my training. And I was introduced to the work of my colleague Bonnie McConnell, who's an ethnomusicologist based in Australia. Found out all about her extremely interesting work, also met Vivek Glover around the same time, got very interested in perinatal and the importance or the potential application of music as a stress reliever, and started jumping into this very different world that I hadn't been in before then. So we started this partnership that we called CHIME, and that's what I'm talking about now. All right, so this is a photograph of a Kanyeleng group in Gambia. What makes Gambia an ideal first location to develop such an intervention? Well, there's a high level of unmet need around mental health. There's 2 psychiatrists for the population of 2.5 million. But alongside this, there's a very rich musical culture. And these are particularly relating to local women's groups called Kanyeleng. Kanyeleng groups are fertility societies that exist in most neighborhoods in the Gambia, and they make a lot of use of music. They do music performances, particularly around community ceremonies, and they have a lot of knowledge about maternal and child health as well as fertility. So this is something that they do on a voluntary basis as part of a, really just as part of community and culture. They have lived experience of infertility or the loss of the child in the first few years of life. And so they really serve as a support group for others in the community. They've become so well known for what they do and the ways in which they do it, which involves a lot of joking and playfulness. The term that they use is tulungo, which is the Mandinka term that sort of means play. And it refers to all the aspects of the performance, the drumming, the whistles, the singing, the joking. Sometimes there's people give some money as well. So the whole experience is referred to as tulungo or play. And the Ministry of Health and Social Welfare in Gambia have recognized the importance of the Kanyelengs as health communicators. And in a context where there is low literacy and a preference for oral communication, they now commission these local women's groups to lead on public health campaigns. So that might be around Ebola, around HIV, around sanitation, around COVID. So they actually have this dual status where they've got their original function, which they do in the community for no reimbursement, but then they get kind of commissioned by the ministry and other groups to lead on public health campaigns. So really, because of their expertise, we wanted to work with them as co-developers and facilitators of an intervention that really utilizes what they know and how they work, and really just simply tweaks things a little bit or tailors it to the perinatal period in particular, thinking about mental health, which is not a specific focus that they've had before. So as you'll see, we worked with them to really do a co-development. So it's really sort of saying, well, this kind of thing is going on to a certain extent. What if we tailored it in such a way that we could actually measure the impact on this specific area of perinatal mental health? And that's what the project was all about. But first of all, we wanted to understand a bit about how mental health difficulties manifest in the perinatal period in Gambia. So we did focus groups with pregnant women, midwives, community health workers, and hereditary musicians as well, who were called griots, to understand something about the local idioms and the role that music already plays in how people might manage their mental health. We also did some measurement work to find out what tools would be appropriate to capture mental health symptoms in Gambia. We did a co-development with 4 different Kanyeleng groups. And then finally, we did a feasibility trial that really underpins the work that I'm doing in the current grant. But it was really to ask, can the trial be delivered? Is it acceptable? Can we recruit? What's the attrition like? How was it received? And was there any potential efficacy as well? So I'm going to tell you a little bit about that. So with the focus groups, one of the first things we wanted to do was to find out some of the terms that would be appropriate in the local context. And although there was no direct translation of depression or anxiety, these are the closest terms we came up with. So in Mandinka and Wolof, which 2 of the main spoken languages, Sondomu Tenkung Balia, lack of a steady mind or heart, and Helbu Dalut, lack of a peaceful mind, in the 2 different languages. So that's obviously really, really important to get the language right. And honestly, the translation work that went into this first phase and is now going into the second phase is, you know, really a complex thing that can't be underestimated, really. The other thing we asked was around things that contribute to having an unstable mind or an unsteady heart. And as per other examples in the literature, the themes crystallized around economic, social, and spiritual factors. So I'll give you some examples. So being in a matrimonial house and yet the husband doesn't do anything for you but squander his wealth is enough reason to have sorrow. Being in your husband's house and he doesn't talk to you, or whenever he calls it means a quarrel, that is a difficulty too. So that's a social one. Economic. If you have nothing, no health, you can't have a stable mind. Being sick and poor, one cannot experience freedom of mind. Freedom means one has good health. And then spiritual. This was really interesting, actually. So there's a lot of understandings of health around spiritual factors. And one belief around why miscarriages occur or infertility is around visits of the spirit husband, the Kunto Fengo. So the Kunto Fengo was thought to have visited this woman in her sleep, and since then she says, I don't have a child, I dream of that evil spirit, and after I get stomach pain, I took all kinds of medicine, I did all kinds of medical tests, so they have seen nothing, and still I don't have a child. So one thing I want to say about the Kanyelengs that's so important, I think, is that they reside in this interesting intersection between spiritual understandings and beliefs around health, because of that's the prevalent understanding in their culture, but also because of the work they do with the ministry. They have some understanding also of biomedical frameworks, so they can speak both languages, and having this plurality of understanding of belief systems is actually really, really valuable for these kinds of interventions, because obviously the acceptability is not going to be high if there's no way to embed it within the sort of prevalent belief systems. So that's quite interesting. And then finally, we asked not only about sort of determinants of mental health difficulties, but how music is used. And one of the hereditary musicians we asked said, you ask if music has the ability to help someone with a problem. Yes, in fact, that's the reason for the existence of music. Arts and culture, in such a situation where one is afflicted with problems, it will now be suppressed drastically. Whoever hears a song in a state of depression shall enjoy a degree of relief. And that really sort of underlines some of the importance of music in everyday life, and how it's also really important for managing social relationships. So yeah, that's, and a lot of the work that Bonnie McConnell has done is around that. She's written a book called Singing the Unsayable, which is wonderful and really unpacks how the Canyalengs do what they do and the role of music as well. Okay, so as I say, we did some measurement work, and we used a very widely used measure, the Edinburgh Postnatal Depression Scale, which can also be used prenatally. And we used the self-reporting questionnaire, which is also able to capture common mental disorder symptoms. But those two measures differ in the sense that EPDS includes some somatic symptoms, like my hands shake, I have no, sorry, the EPDS deliberately excludes items that make reference to bodily symptoms, whereas the SRQ retains those kind of bodily symptoms. And that's important because we actually know that in African populations, mental health symptoms are typically experienced in a very somatic bodily way. So the EPDS, in eliminating such items, is therefore not very sensitive to pick up these symptoms in certain populations. The other difference between the two scales is EPDS is a Likert scale, which is how much do you have this symptom? Yes, very much. Yes, a little bit. Not very much. And that is extremely difficult to translate and to come across. Whereas self-reporting questionnaire just says a symptom and says, do you have this symptom? Yes or no. So it's a binary scale, which is much more straightforward in terms of translation. And what we found was that in the same women, the two scales behave very, very differently. So these cutoffs indicate different levels of severity. And you can see EPDS is showing that in our sample, there were very, very low levels of symptoms. But with the SRQ, you can see what a different picture that is. So that's really telling us that in our context, SRQ is a much more useful measure, probably for the reasons I've talked about, the inclusion of bodily symptoms and the binary response scale. Yeah, now I want to talk about the co-development of the intervention. So let me see. So the formative work had allowed us to understand a bit about how perinatal women experienced mental health difficulties and the role that music played in managing some of those symptoms. And that gave us quite a firm foundation from which to co-develop the intervention with 4 different Canyaleng groups. As I say, the Canyalengs can be considered real experts in the ways in which perinatal women need to be supported. That's what they do, that's what their role is. And it was quite a small step to shape this into an intervention that could allow the impact of what they do to be measured. So what did we do? It's important to say that CHIME is a universal intervention which invites all pregnant women to participate regardless of their symptom levels. As I said, that reduces stigma, but it also allows us to reach the broadest possible section and to have a chance to reduce the symptoms of people at the highest end of the spectrum, while having more of a sort of a health promotion, health prevention angle for people who are experiencing fewer levels of symptoms. So what we did was we did some workshops with 4 local Canuleng groups, where we talked with each group separately about their ideas for the intervention and the songs that they would like to use for the intervention. So they've already got a range of songs. They use these songs that can be well known to the community, and they're real masters at improvising. So they'll take existing known songs and they can just on the fly use new lyrics to address whatever topic they want to use in a very flexible way and in a way that invites participation. So in terms of Canuleng performances, if you think, or sessions, if you think of what would a successful one look like, it's not in terms of how beautiful the sound is, it's in terms of how much people were involved from the community and how much enjoyment there was. So it's definitely not about focusing on a beautiful musical experience. It's about inclusivity, it's around participation, and it's around joy and humor. And I think that's really, really sort of quite unique. So the Canulengs are always laughing, they're always joking, they have ways to honor the women that are there because there's different tribes across the Gambia. So they notice who's there and they sing particular songs to bring people in and to honor people's different backgrounds and tribes. Okay, so in terms of what we decided from these workshops, we decided to have hour-long sessions over 6 weeks. There would be a welcome song and a closing song, and there would always be a lullaby in the middle somewhere. This was the idea that essentially lullabies are something that are known to the older generation, but is slowly getting sort of lost to younger generations. But we introduced this as a tool to think about, to use with the baby after birth. And then many of the other songs were around themes of resilience, themes of the importance of social support, and strategies to deal with some of the common psychological and physical challenges of pregnancy. But as I say, this is a little bit of messaging in terms of these themes, but at the heart of it, we're really thinking about how powerfully music can be used to lift mood. And we also know from the literature that it's a really, really good way to foster social connections. So to sort of sum up the rationale for the intervention, it's music to lift mood, music to bond people socially, and music to message simple messages around maternal mental health. And we developed this mission statement where we basically said we wanted the women to finish the session in a positive mood, feeling part of a supportive group and empowered to cope with some of the common physical and psychological challenges of pregnancy. We did a feasibility trial. Oh, let me give you a quick example of the Canulengs in action. I think I'll leave the clip there, but you can see what they do is really special. There's a few little sleeping babies amid all that noise somehow. But yeah, they're masters at getting people involved in different ways. And I think what's really nice that our colleague Bonnie always tells us is that the way in which people can get involved is very much on their own terms, because the music and the songs are designed such that it's called like feathered entry and exit, basically meaning that they don't really have a start and a finish. You can join in at any point and the music still sounds good. and you can join in very, very different ways. So I think that's like makes it particularly inclusive, and they really encourage people. So we had a launch for the new project, and we went to visit one of the Candyland groups, and they used scarves to throw around people's necks to kind of pull them into the group and get them involved. And a few of the CHIME team experienced that, which was really lovely. Okay. So yes, just to say, we ran this feasibility trial across 4 different clinics. Each of these clinics had a Candyland group attached to it. And we used what's called a stepped wedge design. That means that at each clinic, well, it actually means that first of all, we bring these 2 clinics on board, and we have a period of a control group. So we recruit pregnant women, we collect data in terms of mental health symptoms at time 1, and then 7 weeks later, and then a month after. So this is 11 weeks. These are women that just did treatment as usual. And then at those 2 clinics, we then recruited women to be part of the intervention. These 2 clinics were part of the second wedge. And again, we recruited control women, collected data, and then recruited the intervention. So that was a design suggested by our statistician, Victoria Cornelius. And we were testing it out to see, would that be an effective trial design? Now, this are some photographs of the clinics on non-clinic days. You wouldn't be able to see anything if it was a clinic day because there'd be too many people there. We had a couple of them were more rural, a couple more urban, 2 in Wolof speaking and 2 in Mandinka speaking areas. And yeah, as I say, it was a feasibility trial. So we're asking questions that, you know, did the sessions happen? Who attended? How many sessions? How acceptable it was? So all the sessions happened, and 72% of the women attended at least half. There was lower attendance at the most urban clinic, and we found out that that's related to women having a lot of commitments, being busier, having jobs, for instance. So that's important learnings for future work. In terms of people who, you know, agreed to participate and attrition, you can see some information there. So this is all sort of like, you know, maybe not so exciting, but definitely important for feasibility, to know these things and to inform our future work. Similar attrition rates between 2 groups. Now, with feasibility, obviously, you want to know how acceptable was the intervention. A few quotes. I realized before I got pregnant, I used to become worried. After the intervention, I'm not worried. Your program is good to us. It's beneficial. I learned a new lesson from the program. The first is not to isolate oneself thinking. When you're pregnant for 6 months, you should also go to health centres and take your malaria medication for good health. So some of the messaging the Canulings brought in from other campaigns that they'd been involved with. And, you know, in this context, you know, even really simple, really basic messages can be quite important and really valued by the participants. And right now I'm helping someone and I am a teacher on my own. This does, although we sort of de-emphasized the messaging aspect because we're quite excited about the potential of music around mood and social connection. It is interesting that these kind of the information and the knowledge comes through. And actually this person is talking about, she goes back to her extended community and she passes on what she's learned. So there's these kind of ripple effects. And then looking in terms of potential efficacy. So in feasibility studies, you're not really supposed to look at your outcome measures, but nevertheless, we couldn't help ourselves. And what you see here is the SRQ scale at the first data point at week 7, which is after the intervention, and then after at 11 weeks when the intervention had been finished for 4 weeks. And what you see is that although the treatment as usual group reduced in their symptoms, it's a statistically significant difference between that group and the intervention group, and that is maintained at follow-up 1 month after the intervention finishes. So we're allowed to call this potential efficacy, says my statistics colleague, Victoria Cornelius. And that's because feasibility trials are not not fully powered to look at questions of efficacy. Nevertheless, highly promising. And with all that in mind, we were in a position to really, to apply for larger scale funding to do a full-scale randomized control trial in Gambia. But not only that, we also wanted, yes, so now I want to tell you about what not only to apply for those funds, but we were also successful in getting those funds from National Institute of Health Research, global health research groups. And this now allows us to extend the work into 2 different contexts, South Africa and Lesotho. We also did some formative work already in South Africa under Simon Honigman's leadership, and One-to-One, which is an NGO with community health workers working in the very rural Eastern Cape. They go door to door, the mentor mothers, and support women around every aspect of pregnancy and childbirth. So there's no time to talk about that work today, but we are essentially building on that in the current grant. We're also doing some work in nearby Lesotho, where there's very interesting traditional practices around music as well. So overall, we're really interested to generate evidence on how culturally embedded music-based interventions can be used to improve maternal mental health, but also to build knowledge and capacity to support the evaluation, adoption, and sustainable implementation of these interventions across LMIC settings. And this just shows you a schematic of where we're at different phases of the work in different contexts. So in the Gambia, which I've been talking about exclusively today, we've done the formative work, we've done the feasibility trial, and now we're on to this full-scale trial, which will kick off in the autumn. In South Africa, as I say, we've done this very interesting work, some of which has just been submitted for publication, and we're building on that to do some more formative work, this time not in a rural context, but looking in an urban context of Khayelitsha. Simon is really helping to shape up there, and that's going to lead into a feasibility trial. And then in Lesotho, we're doing partnership building and some formative work. And we're hoping to do a lot of sort of cross-country learnings. And this is a bit...
a few minutes maybe left.
Just a few minutes left, yeah. And this is just the overview of showing what we're doing in that grant around, generating evidence, building partnerships. And then very important to us is capacity strengthening for researchers, for communities, for stakeholders. We've got some really, really good buy-in from ministry colleagues at the highest levels, who are really helping us to think about what this would look like in the longer term. And also just to say, in the work that we're currently doing, we're trying to think under Annette's direction how to think about the economic side of things and how much this will cost and what the benefits that we measure can be. So I think, yeah, just to really acknowledge that highly interdisciplinary, big team of people. The initial phase work had these people involved. The NIHR grant has got even more people involved. We're very grateful to our funders, and we'd be very happy to hear from any of you with any ideas or any comments. But we've also got a website is going to be revamped, but there's papers and there's examples of some songs that the mentor mothers in South Africa composed as well on our project website. So please check it out if you're interested. Thank you.
Amazing. Thanks so much, Lauren. I think, yeah, this definitely has been such an exciting presentation, and it's such a pleasure to be part of the project. We have a few minutes for maybe just questions. I can see that Jeanette has joined. Jeanette, I did introduce you at the beginning. It's part of the core group, so feel free to come in whenever you have time.
Thank you, Annette. I'm sorry I was late. I was back from work late and but I did join near the beginning, so I heard most of the lovely presentation, Lauren. It's really great work. I've been aware of it for a while through Vivette, and it's great to see where you've gotten to. I was just going to say that we use music in our mother-baby bonding programs, and like there's so many levels at which you mentioned quite a lot of the functions of music. I think that the music itself also has a psychological effect, like the type of music, whether it's energizing or whether it's moody and so on. So, I don't know whether you look at that as well, at the actual music itself and its power.
Yeah, thank you. It's actually quite complex. You're absolutely right. And some people sometimes say like, oh, but what music should I use for this particular thing? And we very much, although there are general things to do with, the volume, the musical key, the genre, as you say, it's basically arousal, energizing versus calming. But within that, the overriding factor is preference, what people's personal preference is. And for some people, like I know a musician who now only listens to what's called noise music, which sounds like industrial machinery, sort of like, to me sounds cacophonous, to her sounds extremely relaxing. So these individual differences in preference are really, really interesting and quite complex. So that's why we always are careful to sort of like really remember that there's so much variety in what people actually want to listen to. I'm doing some work around sort of what CHIME can look like in Southeast London, particularly for ethnically diverse communities. And that's been quite interesting. And it's being led by a musician, Namvala, who is a very successful singer-songwriter in her own right, but she's leading these groups. And essentially they're groups that are facilitated group discussion around identity, mood, stress, things, and weaving the music, weaving some musical activities in. And it's quite interesting because the staff that were already running those kind of non-music based sessions, they told us that the music sort of makes some things possible that were not possible before, and it amplifies other things. So I think that's interesting for people who might be really struggling and aren't able to articulate or don't want to articulate honestly with people that they've only just met, or might have a language barrier, or don't feel like talking that day. The use of creative approaches in general, but music in particular, can actually, allow things to happen. This sort of an icebreaker effect. There's trust. The participants also share music to make a playlist. So that's quite nice, because then that's a thing that they all have together that they can listen to between the sessions. So we're doing quite a lot of kind of cross-site learning, a lot of global south to global north knowledge exchange as well, I think, which I think is interesting because, there's a lot of social prescribing stuff, community assets, cultural assets. And if we look around in a UK context, I think, what are the community assets? What is the culture here that can be leveraged around health? And in contrast, in Gambia, in South Africa, in many places in the global south, it's a very rich, cultural assets, and all of that kind of informal community-based stuff is absolutely, so potent, I think, in terms of what it can offer, if it's just sort of tailored in the right way. And then, there's other questions about how to embed it within health systems and how to have channels of communication between the clinic staff and the cannulengs, and how that all works. But so we're developing like an implementation guide that we'd love to offer to people who might like to think, do they like to use music in certain ways, and what would that look like for their context? And in Gambia, it's all about the musical participation, but in Southeast London, it's using music to interweave alongside a psychosocial intervention, but it tweaks it in a certain way and allows certain things to happen. And that might be the direction that we go in South Africa as well. So it's quite versatile.
Amazing. I think that's really such a good comprehensive answer. And I think like some of the exciting bits, Lauren, are around, I think the learning you are actually taking in your study from low income countries to high income countries, which is usually, it's not very often, isn't it? It's not very common. So it's really nice, I think, to have that as part of your study. And the other thing, I don't know if you wanted to kind of like mention that or elaborate on that a little bit more, but you know, especially toward the end, you kind of alluded to the capacity building part. And I think it's so important that, you know, I'm obviously part of the project, and I've really seen it like being in the Gambia, how much support the project has from really very senior kind of like government officials and singers that are very important in the kind of cultural context. And I just want to kind of like ask about how you made, I feel like, you know, a lot of that kind of like knowledge mobilization, you almost did intuitively, but at the same time, maybe you want to reflect a little bit on some of the learnings from that kind of like process of actually getting everyone on board years and decades ago, really.
Yeah.
Decade? I don't know.
Well, I always say that it's due to Bonnie, my colleague Bonnie McConnell, because she's been working in the Gambia for 15 years. She was living there for 5 years. She's fluent in the languages, the dances, the music, you know, she already had partnerships with the head of health communication at the ministry, a guy called Buba Darbo. And Buba's mum herself was a Kanyaleng. So Buba was really, you know, he knew all about the Kanyalengs. And his department at the ministry was already in regular touch with the Kanyalengs for all these kind of public health campaigns. So Bonnie was already working with the ministry, and that gave us an excellent sort of platform to build partnerships. So the first phase, which was funded by something called Global Challenges Research Fund, which is in the UK, was partly Medical Research Council, partly Arts and Humanities Research Council, but very much kind of identifying a challenge in a low or middle income context. But it was funding to build partnerships. We did a lot more besides building the partnerships because, in a sense, we already had some strong partnerships, not only with the ministry, but also with the National Centre for Arts and Culture, who've been absolutely critical, because they're kind of a government department, but they are the holders of the cultural knowledge. Now, Gambia is really, really interesting, and UNESCO are recognizing that Gambia have a lot of what's called intangible cultural heritage. So things that, not objects, not places, but things like rituals and practices. And our colleagues there, so Hassoum Cissé and his colleagues are they're going to 30 communities. It's a UNESCO project. And they're asking those communities, what are your most valuable cultural heritage things that you prize? And Kanyalengs are one of them. But the other things that they have are fishing practices where they use particular nets and they use particular bones, and everything's very sustainable. And then there's songs that people use in the fields for farming. And so there's specific things that, you know, there's just a cultural richness there. But the project is all around how we can value these practices to suggest that they contribute to you know, the UN sustainability goals in these particular ways, and therefore they must be protected. And how can they be protected? Because, you know, with globalization, a lot of these things are just dying out, or even, you know, people in the more metropolitan areas will think like, oh, that's not very relevant, that's not very, you know, modern, and I don't want anything to do with that. But it's, you know, there's so much value. And I think that's kind of why we feel that this is fairly unique. But also, you know, obviously there's a lot of interesting things that are Gambia specific, but in South Africa, the mentor mothers and the, you know, the prolific use of music in that context is just as much richness there. So that contextualization is super interesting.
Thank you so much. Sorry to interrupt, but we have to kind of bring it to a close now.
Sure.
We only have a minute left. So just really to thank you and everyone who attended. So we keep going with those webinars. There's always only a little time to really talk about what we actually want this group to kind of like look like going forward. But we are still trying to kind of like keep it kind of like going, expanding. So please do tell other people about it. Ask people to sign up if you think it's a kind of like worthwhile, kind of like group. And yeah, thanks so much. And we will be in touch with kind of like the next webinar. Thanks. Amazing.
Thank you. Bye-bye.
Congratulations. It was excellent. Bye.
Oh, thanks, Adelina.
Thanks, Adelina.